At ASCO 2017, Dr. Tony Mock presented the early results of the Archer 1050 trial that directly compared the second-generation irreversible EGFR inhibitor Dacomitinib to the first-generation reversible EGFR inhibitor gefitinib in 452 patients with previously untreated EGFR mutation-positive non-small cell lung cancer, and these patients did not have brain metastases. The trial was notable for a significant improvement in progression-free survival, and I'm showing the PFS curves from the subsequent publication by Wu and colleagues in Lancet Oncology. And this is notable for a hazard ratio really quite impressive, 0.59, and a difference in median overall survival of 5.5 months, with the Dacomitinib arm getting out to 14.7 months. Really quite good, but this agent has had a challenge with the toxicity profile. Specifically, there's high frequency and significant severity of diarrhea, of rash, of paronychia and stomatitis, and because of these issues, 2/3 of the patients, 66.5% on the Dacomitinib arm, required a dose reduction compared to just 8% of the patients receiving gefitinib. Now this year at ASCO 2018, Dr. Mock again presented results from this trial, including the overall survival, which is now significantly superior with the Dacomitinib arm, and a difference of about 7 months. It is also statistically significant here shown, and importantly, Dr. Mock and colleagues showed that the benefit in terms of overall survival was present in both of the common activating mutations, the exon 19 deletion and the L858R substitution mutation on exon 21. So the question is whether this should now become a serious contender as a first-line therapy, especially because patients who start with Dacomitinib still have the option of pursuing subsequent treatment with the third-generation EGFR inhibitor, osimertinib, at least if they have the T790M mutation at the time of acquired resistance. And I think there are several limiting factors that will lead me to be not especially inclined to pursue Dacomitinib over osimertinib here. Now, this trial, Archer 1050, does have a progression-free survival benefit as well as an overall survival benefit, but there are some limitations. First, this comparison is against what I would consider to be the weakest competitor in the family of EGFR inhibitors with gefitinib. It's not markedly inferior, but I would say that the preponderance of evidence suggests that gefitinib is the weakest of them. Importantly as well, in this trial there were no patients with brain metastases allowed, and one of the big strengths of osimertinib is its activity in the brain in terms of leading to tumor shrinkage of existing brain metastases and in leading to a delay in subsequent brain metastases. And patients with EGFR mutations are among those who have the highest risk of developing brain metastases, or as the first or only area of disease progression. Now, there is a theoretical benefit to allowing osimertinib as a crossover by not pursuing it first line, but in this actual study, Archer 1050, only 10 to 11% of the patients actually on the trial subsequently received osimertinib, and it really remains to be seen whether that would happen very much in clinical practice. And in fact, if the majority of patients, as high as 50–60%, who were ultimately T790M positive did cross over to osimertinib, that could very well lead to kind of regression toward the mean and wash out any benefit. So I think, though, that at the end of the day, one of the biggest factors is the toxicity profile. Dacomitinib is really a difficult agent for patients to receive, and even grade 2 toxicities like diarrhea, rash, stomatitis can be a real problem for patients when we're talking about giving this for a prolonged period of years, as we hope to be doing. When you can give an alternative therapy that is not only very effective, but is also very well tolerated in the majority of patients, and that has demonstrated activity in the brain. And so I would say that in patients with an EGFR mutation who have the potential and even probability of being on their first therapy for what we hope will be years, quality of life and the tolerability of treatment matters very significantly, as does the ability to control CNS disease well. Because of this, I would say that osimertinib remains a higher priority, and if I were considering doing a different approach and saving osimertinib for later by giving a first or second generation EGFR inhibitor prior to that, I would be thinking very seriously about a combination with chemotherapy. And in a subsequent video very soon, I'll talk about the data from Japan that would lead me to think about this as a very promising approach. We'll talk about that very soon. In the meantime, I hope you find this interesting, and I hope you will like, comment, and subscribe. Very interested in your comments because there's certainly a gray zone here and a lot of ways to interpret these data.